On behalf of Dr. Agarwal's Institute of Optometry, I extend a hearty welcome to each and every one of you for our Optometry series. Here we are with episode 9, and the topic for today's series is the role of optometrist in glaucoma diagnosis. I'm very happy to welcome our Research and Innovation HOD, Ms. Maheshwari ma'am. Hi ma'am.
Hello. Thank you, Gomadi. 1 second. Can you mute? Oh, yeah. So I'm very happy to welcome our guest today, Ms. Shenbagam N. So I know her since more than 20 years, and we studied together, and we played together. We had nice time together, and very happy to invite her as a guest today. So she was heading the glaucoma department in Shankara Nethralaya. So she was a senior optometrist, and entire glaucoma diagnostics, glaucoma workup, and glaucoma publications. Her thesis work is also from her MPhil work is also from glaucoma. So she knows the in-depth concept about different diagnostics like UVM. So the complicated stuff and all. So it's right now she's working in Sushant University, and we can see that she's having some responsible position over there, and she's so busy with her exams and all. So we are so happy that she could spare some time for us in spite of her schedules. So I'm very happy that she's here, and I would like to take Shipana for a formal introduction and welcome Shipana.
Good evening, everyone. Today's moderator is Ms. Shenbagam. She got her PhD scholar in City University, Ludhiana, Punjab. Working as assistant professor and program coordinator of
a voice break down.
Shipana.
1 minute, Shipana.
Hello.
Your voice is breaking. Just a minute.
Ma'am. Hello.
Shipana.
Yes, ma'am. Yes, ma'am. Kekkudu.
Your voice is breaking. Just wait.
Yes, ma'am.
I think different Wi-Fi connection opening. Let us start.
So, meanwhile, Shenbagam, you can tell a little bit about yourself.
First of all, I would like to thank this entire team for giving me this opportunity. Thanks, Maheshwari, Jemima, Gomati, who are all interacting with me on and off in between, as in we could spare time. So thank you for this opportunity to the entire Agarwal team. I'm grateful for this. And what I have just moved from there to here, maybe since past 5 years. So I was just into the academic line since 5 years. I was an Amity previously, and my current association with Sushant University, which is in Gurgaon. So it's a totally different experience initially, but now I could get hold of all the set of students, young generations, which is interesting to interact with them and their passion towards optometry. That's a different thing which I'm exploring here too. And I think the young generation are easy going, and they are able to adapt things, and they are eager to learn. This is what I have seen so far, and hoping my experience will be the same too in future. So that's about it. If you want me to ask, or if you want me to say something specific, maybe you can ask me.
I hope Shipana can continue. Shipana, try and see.
Unmute Shipana.
Yeah.
Good afternoon, everyone. Today's moderator is Ms. Shenbagam. She got her PhD scholar in City University, Ludhiana, Punjab. Working as assistant professor and program coordinator of the Optometry Department, School of Health Science in Sushant University. She completed her BSc Optometry and MPhil Optometry at Allied School of Optometry, collaborated with BITS Pilani, Chennai. She has 12 years rich clinical experience as senior consultant optometrist in specialty OPDS, a glaucoma diagnostics including OCT, UBM, HRT, and visual field at Shankar Nethralaya, Chennai. She had the privilege to continue her career as lecturer in her Mother Institute Elite School of Optometry for over a decade. She also worked as assistant professor in Department of Optometry and Vision Science, Amity University, Manizar. She has area of interest in teaching geriatric and pediatric optometry, ocular disease, and diagnostics and research methodology. Her work on diagnostic sensitivity of ultrasound biomicroscopy in identifying clinical aqueous misdirection syndrome was presented as poster presentation at the International Conference ARVO Hawaii 2018. She also published an article Objective Retinoscopy, a clinical perspective Delhi Ophthalmological Society DOS Times 2020. Teaching is her passion and evoking the young minds with all that she knows add zeal to it even more. She is very grateful to the past and present institution for all of them today. She was invited as guest speakers for Indian Vision Institution, CL Gupta Eye Institute, Moradabad, Optometrist to National Optometry Conference, Gorakhpur for the year 2023. I'm very much happy to welcome you for Optometry series, ma'am. Thank you so much for coming. Now the speaker for today is Ms. Harimahalakshmi R. She's a fellow Optom student. Now I request Ms. Harimahalakshmi to start the presentation.
Thank you, Shifana, for your wonderful introduction.
You're welcome, ma'am.
Thank you so much, Shifana. Before which I would like to welcome Jemima ma'am also. Thank you so much for joining, Jemima ma'am. You've always been supporting us. Thank you so much, ma'am.
A pleasure. Thank you.
Thank you so much, Shenbagam ma'am, for joining us amidst your busy schedule. Thank you, ma'am. I request Harni to start the presentation. Yes, Harni.
Good evening, everyone. Today's topic is role of optometrist in glaucoma workup. Myself, Harimahalakshmi, a fellowship in clinical optometry, Dio. Introduction. Glaucoma is one of the major worldwide causes of irreversible blindness. It is not a single disease, but a group of disorder characterized by potentially progressive optic neuropathy that is associated with irreversible visual field loss as damage progress, and in which IOP is a key modifier factor. Prevalence. It is reported that the age standard prevalence of glaucoma is approximately 3 to 5% in the population aged 40 years old and older worldwide. It is expected increase to 112 million people in 2040 due to rapid increase in global population aging. And prevalence of primary open angle glaucoma of 4.2%, prevalence of primary angle closure glaucoma of 1.09%. Glaucoma, a global disease burden. A global disease burden of glaucoma in 204 countries are shown in the picture.
Sorry, in between, let's have some interactive sessions. Participants from YouTube and Zoom try answering some quiz questions in between. Quiz number 1. Which population is prone to get glaucoma? According to epidemiology, try answering which population is very much prone to get glaucoma.
You're not giving options so that they can comment.
Next time we'll try it up now. Because it is broadly classified as blacks or whites or Asian population, European population. So let them answer whatever it is. Arani, you can continue now.
Classification. There are two types of classification: traditional classification and modern classification. Traditional, there are 4 types of classification. First one is etiology, anterior chamber anatomy, age of onset, and pathogenesis. In etiology, there are 2 types, primary and secondary. Anterior chamber anatomy is there are 2 types, open angle and closure angle. Age of onset, there are 3 types of classification, infantile, juvenile onset, adult onset. Pathogenesis, there are 2 types of classification, congenital and acquired. Modern classification, there are 3 types of classification. First one is primary open angle glaucoma. Second one is primary congenital glaucoma. Third one is primary angle closure glaucoma. Risk factor. Is age, people over age 60, physical injury to the eye, mostly caused trauma, corticosteroid use, prolonged use of steroid uses, other eye related risk factor, it mostly common secondary angle glaucoma, medical condition, diabetics, high blood pressure and heart disease may increase the risk factor of developing glaucoma. Family history, having a family history of glaucoma increases the risk of developing it. Race, African Americans are more likely to get glaucoma and suffer permanent vision loss and their Caucasian. What would be the patient complaint? Mostly it causes an asymptomatic, silent disease that damage the eye slowly. Other symptoms include pain, redness, halos, photophobia, loss of peripheral vision, sometimes associated with nausea and vomiting. The glaucoma continuum. It is a glaucoma pathophysiology condition. Normal, first it will occurs as normal and then it undergoes the apoptosis and it leading to ganglion cell death or retinal nerve fiber layer changes. Until here it is an undetectable. Next, vision and visual field changes occur. When visual changes become severe, it leads to visual impairment. Diagnosis. The study on comparing trained optometrist and glaucoma is compared with the consultant ophthalmologist. Provide satisfactory outcome. Standing optometrist identifies equal to junior consultant. Optometrist role in diagnosing glaucoma. There are 3 types of divided: diagnose, refer, and co-manage. First one is diagnose. It requires skills and knowledge. Refer, it requires proper patient care, good communication with referral areas, and co-manage should follow up and monitor. Skill to diagnose. Clinical diagnosis needs expertise in this blinding disease. Imaging techniques play a major role in diagnosis. First one is detailed history and then comprehensive eye examination and then anterior chamber depth grading and tonometry and pachymetry and last OCT and perimetry. History. Detailed ocular history should be updated. First one is patient purpose of visit. Next, ocular history and then family history, then risk factor and medication, etc. Comprehensive examination, it includes vision, refraction, extraocular muscle movement, color vision, pupillary reaction. A slit lamp examiner, it includes anterior chamber depth grading. We can see 2 types, gonioscopy and Van Herrick principle. And then IOP, iris defects and signs of secondary glaucoma, pigment dispersion and pseudo exfoliation. Fundus examination, we have to see cup disc ratio symmetry, neuroretinal rim, disc and blood vessels. Anterior chamber depth grading. First picture, it's a grade 4 because of lens and iris part will be attached. Next, third one is lens and iris part attached in between smaller gap. Second grade is iris and lens in between gap is long, and first grade is lens and iris part in between gap is too long. First grade 1 it include squabble line and anterior trabecular meshwork, and grade 4 it includes a squabble line, trabecular meshwork, scleral spur and ciliary body band. This is a picture. It includes first the last part is iris, and then in front of a small gap it's a scleral spur, and then a small line it will a trabecular meshwork, and then and another line it will become squabble line. It's a primary open angle glaucoma.
Okay, next is we'll see the quiz number 2. Seeing the ASOCD picture, comment whether the angles are open or closed. Participants from YouTube and Zoom can post the answers in the comment box.
If it is wrong, no problem. No, just post something. You have only yes or no option.
Yeah, it is open.
Anyway,
You are typing anyway, it is open or closed only. Yes, Arani, continue.
Fundus examination. Fundus examination. First one is a healthy normal cup disc, and second one is cup disc is enlarged. That one is glaucoma, increased cup disc. And second picture, first one it will denote a splinter hemorrhage, and second one is Biontic sign. ISNT rule. The INSNT rule rim width which decrease in the order of inferior and superior nasal and temporal. Normally the neuroretinal rim is thickest inferiorly and thinnest temporally. In glaucoma, there is a vertical thinning with atrophy along the inferior and superior rim. If the optic disc does not follow the ISNT rule, it may have had glaucomatous changes.
Okay, ending up into question number 3. What is a normal cup disc ratio? We'll wait for 20 seconds. Try answering in the chat box.
These are simple questions. No, if it is wrong, also it's okay. Write something. You can try always listen.
Yes, Arani, continue.
IOP measurement. With respect to glaucoma measure, appellation tonometer is curical, and consideration of corneal thickness of for accurate IOP values are important. NCT can help in case of glaucomatous condition.
Question number 4. What is a normal IOP range? Continue, Arani.
Corneal thickness. CCT is low, IOP will be underestimated. Higher CCT and IOP will be overestimated. A reduced corneal thickness of 0.45 mm could produce an underestimation of the IOP by up to 4.7 mm Hg, whereas an increased CCT of 0.59 mm could cause an overestimation of 5.2 mm Hg. Perimetry. In the first picture, it's shown enlarged blind spot, and second one it's shown a paracentral scotoma, and third one is temporal wedge, fourth one is superior arcuate, and fifth one is tubular vision. In this case, there is an enlarged blind spot with nasal depression point. Optical coherence tomography. First one is a key parameter, second one is nerve fiber layer, and third one is the RNFL deviation map. Fourth one is neuroretinal rim thickness. Fifth one is RNFL TSNT graph. Sixth one is RNFL quadrant and clock hour. Seventh one is horizontal and vertical B scans. Eighth one is RNFL calculation circle. In this case, right eye superior and nasal is borderline. Inferior is thinning, and temporal is normal. In left eye, superior and inferior in borderline. Superior and inferior in thinning. Nasal is borderline, temporal is normal. And second one, first OCT is a normal OCT, and second one is double humping. Double humping graph, it touches to the red line. Ganglion. Ganglion cells, OU report will analyze the ganglion cells of retina. Areas of thinning will be shown in the red. Other imaging technique, there are two, HRT and OCTA can help. HRT is similar to OCT, double humping patterns and thinning will be seen. And OCTA, first one is blood vessel, it's normal, so it is a healthy. Second one is glaucoma suspect, the blood vessel will be decreased, and glaucoma, there is no blood vessel, it is decreased completely.
Okay, last question for today. Name the angle structures.
So some of them have answered correctly for the previous questions.
Yeah.
We would like to congratulate those of you who have answered as 10 to 21.
Yes. Yes, sir. May continue.
Glaucoma, first one is a normal, cup disc ratio is normal, and second picture is cup disc ratio is enlarged, so the vision will peripheral vision will damaged. Referral, once suspected or noticed, to refer to an ophthalmologist for management. After treatment option, routine follow-up is necessary, giving proper care. Co-manage, during follow-up, co-management with ophthalmologist is needed. By repeating the investigation, efficiency of the treatment can be understood. Giving suitable counseling also play a critical role in day-to-day activities. Conclusion, glaucoma being a global disease burden, mandatory screen for all people over 35 years is important. Comprehensive eye examination shouldn't be missed. Avoid missing out threatening complication or investigations correlated with clinical findings. This is my reference. Thank you, ma'am.
Thank you so much, Harini. Now request our moderator to add some points.
Okay, so it was a good presentation. I just want to share few additional things. Maybe the presenter can scroll the slides so that I can tell, Harini. So the first thing is, if you'd like to, I would like to share my views and add little more points. Maybe it will be useful for all of us as we are anytime seeing the patients, isn't it? So can you go to the slide number 9? Okay, so I am just going to try to make this slide very simple because this is very most important. So what is this continuum says here is the undetectable disease, asymptomatic and functional impairment. This is how the cycle continuum goes. So here the undetectable disease is the apoptosis. Apoptosis means cell death. So the problem here is before the structural changes occur, even like 40% of the structural damage would have already happened. But until and unless this amount of damage is happening, the patient will not find any symptoms. So this is the seriousness of this disease called glaucoma. Why? Because it is a silent killer. So by the time he comes or reports to the clinic for a comprehensive examination, if he is already glaucoma first time coming, then we have detected, it means at least 30 to 40% damage in the structural area has already been started. So that is the most important thing which we have to remember. So from this phase to this phase, it is very crucial to detect at the early stage. So that is also one of the reasons where she has already mentioned that the comprehensive examination should be started even after 35 years. That means a routine examination right from your history till your fundus examination and cup disc finding ratio and everything should be checked within that period onwards, so that a periodical health eye checkup is mandatory along with the health checkup. So this is point number 1. The second thing, the prevalence of glaucoma is very high and we are at the top risk too, the Asian countries. So why am I saying all these things? Because we as an optometrist should try to find out the patients who are glaucoma suspect or who are in the borderline category to detect and try to make them as a follow-up visit so that we are picking it up at the early stage and preventing this constriction of visual field or whatever it is, along with the nerve damage. I hope it's very simple and clear. This is how we have to understand. Point number 2. The third thing is how we can go about. Okay, so can you please go to slide number, I think 13, I'm not sure, the history slide, please. Okay. So here, see, patient comes as a layman to us and our role is much more important here, followed by the series of objective examination. So this is your history taking, which is very important. What I would like to keep in your mind is, first time if the patient is coming and see the age and see the occupation of the patient and from which country, or sometimes people come as international patient also, right? So see whether they belong to Asian countries or somewhere else or African. Why? It has a relation. Those population, there is a demarcation where one suspect is having more incidence of open angle and other under angle closure. Asian population will mostly have the incidence of angle closure. So that you have to see. And second thing is, what is the present complaint? Mostly we will concentrate on blurred vision, distance near, etc., etc. But along with that, you should also ask, how is your field of vision, or how are you able to drive properly? Are you able to see things? Just take the key point and build on that and go. If the patient is saying tick for the answer which you are expecting, then probe. So like that you have to go ahead. The third thing is, like when a patient is saying that like headache history or migraine, or again, one more important point I would like to add here is, you might think migraine is common and it is okay, but the medication which the person is taking for migraine is important. For example, topiramate. Topiramate is the tablet which they usually take. So when they take that, what is the relevance here in history for glaucoma is, again, this topiramate can cause your anterior chamber angle narrower. So what will happen? Angles will be narrower. So therefore it leads to closed angle, right? Then how will the aqueous humor gets overflowed or outflow? That outflow passage, trabecular pathway is affected, isn't it? So that is the reason we have to see this. So maybe the pressure increases because of that. You might think 30-year-old male, Everything is fine, plano 6-6, everything, but why the angle is shallow? Why? What is happening? Then the pressures are 25-30. Why? Maybe the reason is this. If you go back, literatures have already shown that, but we as an optometrist sometimes in our busy seeing OPD patients, when you have too many patients, sometimes we might skip. But that is also we shouldn't miss, and we should try to take as much relevant details as required. The ocular history, again, you ask the symptoms. See, now this is for the first time patient. Suppose the patient is already a known case of glaucoma and is coming for the follow-up. Here, what will we ask? Of course, your current medication, that is your anti-glaucoma medication, and how many times. That is more important, like 2 times a day or 3 times a day. And here, the most important thing is glaucoma medication should be written with timing. Suppose Timolol 2 times. When is the last medical application? That is more important. In your documentation, your last medical application should be there in current treatment, because that has an effect. Suppose if he has taken 2 days before he has discontinued because of his busy schedule, he forgot to take the medication along with him when he was traveling, and today he has come by mistake, and you are checking the pressure and it is little high. So he might not think that it is really important, it's hardly 1 or 2 days. No, that does matter, and therefore there may be a rise in the IOP. So again, your current treatment is very, very important if it is already a known patient of glaucoma. Okay. Again, if it is already a known patient of glaucoma, you should ask. Maybe he's coming for the first time to the hospital, to your hospital, where you're checking the patient for the first time, but he's already a known case of glaucoma. In that case, what are all things which we have to document is very, very important. First is your baseline IOP. What is baseline IOP? Your first detected rise in the intraocular pressure. As you all mentioned, 10 to 21 is the normal intraocular pressure. You ask him when was the pressure rise first time, maybe 5 years, 2 years, maybe, and you ask him, maybe he will not remember or hardly he will say something. In that case, check with him whether he has brought any previous reports and try to find from there whether you can document something. Okay. The second thing is, after mentioning, this is called baseline IOP. If the patient is an old patient, you have to even more be specific in all the things which you are documenting. For example, I told baseline. Second baseline fields, the first time when the patient had undergone fields. Why? Because to see how the glaucoma has progressed right now. Is it okay? Is it in the consistent stage, or there is a severe fluctuation IOP followed by the cup disc ratio changes in the retina followed by a visual field changes? Then may be a problem. Either the rate of the disease is progressing, or there is a problem with the compliance, whether the patient is applying the drops regularly or not. These are all the things which we should be very careful in asking. Then your baseline fields report, you ask the patient and see what was the initial field. Again, why? Because from that time onwards till today, what is the rate of change in the progression of the visual field? Suppose the patient is having a superior arcuate, early superior arcuate, and is it still superior arcuate, or it has furthermore gone down to biarcuate and the visual field has come down? That we have to write. So baseline followed by the latest last check IOP elsewhere along with the visual field. Why? To understand the progression of the disease. Now, suppose the patient is coming for maybe he's a known patient for 8 years or 10 years or more, then how are we supposed to write everything? So just mention the key points along with the last 6 months data. That is more important. Okay. So that is another thing. And one more thing which I would like to add here is, as I mentioned, current treatment. Last medical application. Yes. Suppose it is Lumigan, applying once at night. So because of Lumigan, what are the changes in the eye? That is also important. Why? Because the person using Lumigan will have long lashes and pigmentations. Why pigmentation? The patient is instilling eye drop, by mistake it would have gone in the lids, isn't it? It's common. But that might cause every day the same cycle. If he's continuing, then there might be pigmentation in the below the lids, and the lashes will grow longer. So this is one of the effect of Lumigan. And the third thing is the lashes and the below the skin. And the third thing is your pigmentation on the conjunctiva. Sometimes the conjunctiva will not be very clear, or some people will be very sensitive to this drop. We don't know. They are each patient comes without a different thing, right? All of us are not same. So they might come with the different allergic reactions. So what will be the next step? Either we have to change the medication or see what is the next alternative. So all these things only the optometrist has to mention in the history, so that when the patient is going for the final consultation with the ophthalmologist, they will just overview and change. If the patient is more symptomatic, the patient may go and report. But suppose if the patient is not able to tell or he forgot to tell, our documentation is already speaking. So our documentation is very, very, very important in history. This is very in all the things, but history plays a very crucial role. And since all of us are involved in this, I think we should take the initiative. And the first point of contact is us only, right? So we should do. So next comes your family history. All of us know, yes, glaucoma is a hereditary disease. So obviously you should write family history of glaucoma, who in the family has, whether in the maternal side or paternal side, or whoever is having, or the own mother, father, whatever it is, uncle, aunt, you have to mention everything. And then risk factors. What is mentioned here as a risk factor? Again, age is a risk factor. And the other systemic diseases, hypertension, diabetes, all these are the risk factors. So this comes into your general health, where you can ask for the systemic medications, and then your current treatment for the systemic medications, and plus your last recent investigation of your blood pressure or diabetes or whatever the reason things, you have to document that. So everywhere recent investigation is important, both for the ocular thing as well as for the general history. And medications, I have talked enough. Medications related to the health wise, you have to mention. And one more thing is, people who are asthmatic, you should write history of asthma. And why I'm saying here is, at least most of the patients might be using steroids, that is the nasal spray, without their knowledge. Doctor would have advised only once, but the patient would have said, it is winter season, so I'm trying to use twice or thrice without even doctor's prescription. That is on my own wish because I'm feeling comfortable. Why? Again, here it's important because there might be a chance of taking steroids, and that might cause a steroid-induced glaucoma, which comes in a secondary glaucoma. Okay, so all these things you have to mention it very clearly, and along with this, you have to write the allergic history, drug allergy, and which drugs the patient is allergic to, whether it is to sulfa, penicillin, or any eye drops, Dorsox, it's an AGM, whatever eye drops also, anything. You have to write it and underline it and bold it so that the consultant sees, and he is going to be a little careful, and he will tell this should not be used. And one more thing is, sulfa and penicillin is mandatory, and it is related to glaucoma also. Why? In the YAG-PA, suppose the patient is undergoing YAG peripheral iridotomy. So in that case, they will give you a tablet called Diamox. So that Diamox, if the patient is allergic to any of the combinations, they will not give, because there is no point in giving, and so they will try the other alternative. So hope my explanation is clear. So please be careful with this. I would like to ask the presenter to go to the slide 14. Maybe we'll talk about the next thing. Okay, so she has mentioned what is the comprehensive examination which we do here. So rightly mentioned, vision, refraction, extraocular motility, color vision, pupillary reaction. Now coming to pupillary reaction, when there is an advanced glaucoma stage, there will be RAPD. So you have to measure RAPD, and you have to always write how is the pupillary reaction. Okay, there are grades of RAPD. If you can grade it, well and good, grade it and document it. And the second thing, ma'am, when should I do this RAPD, or when can I expect this RAPD? So maybe one eye is PL plus or HM plus or CF, other eye is 6/9. You understood? Unequal visual acuity. In that case, please don't forget to check for RAPD. I'm not saying only for this patient you have to check. You have to check for everybody, but a little more attention here. If it is related to glaucoma, then you can expect some RAPD changes there. Okay, so RAPD. So now before coming to the slit lamp. So when you know, now you have done the history, you have done the visual acuity, refraction, and pupillary reactions, everything is done, and the patient is saying you suspect glaucoma. What is the next thing which you have to do? Maybe you can do a qualitative test called confrontation, which is to assess your visual field, right? So you can do a confrontation, which is a qualitative assessment done by the optometrist. That can be added here. And then you go for slit lamp. And slit lamp, what is the first thing we have to do? You all know, from lids you start seeing, but give more attention. to the history complaint. So history, the patient would have told, I'm allergic to this drop. So what is the area which we have to see? We have to see the conjunctiva, whether to see papillae, follicle, whether there any allergic reaction because of this drop. So try to go back to your history and come back to your examination. Only that will help you. Otherwise, we'll be just seeing, and we are also not sure what we are examining, and finally it's going to take time. It is going to stretch your time. So basically, see, when you have done everything properly, just cross-check and see, okay, I have to see this, look for this, so that I'm not missing anything. So that clarity should be there before you see. So based on the complaints. The next thing is, the most important thing you should remember is ocular surface disease. I think everybody would have heard about this word right now. So this ocular surface disease is associated with glaucoma medications as well. Why? As I said, glaucoma is a chronic condition and patient is going to apply for a long time. And as the patient is applying anti-glaucoma medications for a long time, obviously, if it is in the form of eye drop, again, there are going to be changes in the sclera, conjunctiva, all the things that might cause the ocular surface disease. Okay, but why it causes? Because the anti-glaucoma medications has preservatives, isn't it? So why preservative? Because the effect of the drop will be sustained for a long time. That's why we have to add the preservative in the drug. So, and that preservative may be causing this allergic reactions. So that is the reason most of the people who are using preservative drops, they land up in ocular surface disease. So if it is chronic and using for a long time, they might end up this. So in that case, just try to see the other structures also. Maybe you can stay in and see for the other reactions. Okay. The third one, and the studies have shown that the drugs which are not having like any preservative free, then the reaction is less. That's what studies say. So all these things, but the other aspect of this is this preservative free drops are expensive. So just check what the drop the patient is using and document it and check for the simultaneous subjective findings in your slit lamp, objective findings. Okay. So now coming to the slit lamp, she has mentioned about iris defects. So see, we will see everything and then only we will take 80, right? First, we will see the structures, cornea is clear or there is any staining, punctate keratitis or corneal edema, all these things we will do, right? So just see every layer clearly and then you will be seeing your iris. What is the most important to see here is neovascularization, that is rubeosis iridis. That should be, you should see here so that you are missing. See, early rubeosis, which is just a speck, that is a one red dot somewhere in the pupillary border, you are picking it up. Then please don't dilate, even if it is grade 4, even the pressures are normal within 15, 16, etc. in both the eyes, please document gonioscopy. Why? To see the neovascularization or what is happening, everything has to be documented. So gonioscopy is mandatory. The next thing is rubeosis. Advanced rubeosis, we will say, for example, in diabetic retinopathy or diabetes patients, obviously rubeosis will be seen, but the early rubeosis will be missed by mistake or we wouldn't have expected. So my point adding here is to be careful in assessing all the things very clearly. Okay. Now next comes the anterior chamber grading. That is your one-hairy grading. So one-hairy grading is very important because based on this only your gonioscopy has to be done or not, which you have to examine. I do understand you will check pressures, but suppose the pressures are 16 and 17. Okay. And if the angles are grade 2, then what we will do? We have to do the gonioscopy and send for consultant permission. We cannot dilate. You might say, ma'am, it's normal. No, because the anterior chamber is 2. Anything less than 2, you have to be very careful and do the gonioscopy. And if you're not familiar with gonioscopy, just write in that flow chart saying, please, gonioscopy is required before dilatation. At least this instruction you can write and send it to the consultant. And reason, if you want, you can mention there itself AC grade 2 and whatever you want to add, you can add. Okay, so how to check this ACD? ACD is, what is ACD? Anterior chamber, that you all know that. But what is the logic behind that? So where are we checking that? We are checking in the limbus side, right? So approximately 1 to 2 mm before the limbus, you keep the strip, parallelepiped beam, and you see the difference. So basically, what are we seeing? We are seeing the peripheral corneal thickness. Okay, the distance, the thickness of the peripheral cornea and the beam from the iris to the cornea, that distance. These two distances are compared and it is given as one-hairy grading. Okay, so from grade 4 is if the peripheral corneal thickness width and the shadow of the iris and the cornea distance is equal, then it is grade 4. Okay, and if it is half of the peripheral corneal thickness, the distance of the iris and the cornea, the shadow, it is grade 3. And if it is 1/4, it is grade 2. And if it is less than that, it is grade 1. And if it is 0, then it is slit angle. There is no space between iris beam and the peripheral cornea. So that is grade 0. So anything from grade 0 or slit angle to grade 2, gonioscopy is mandatory. Very much important, where please don't dilate. Why? Because 4 quadrants, if at least 2 quadrants or 3 quadrants are closed, then the IOP is going to shoot really up after post dilatation. So if you're for everybody, there will be a 2 to 3 mm increase. Even for us normal people, if you get dilated, your pre-dilation, the IOP will be 14 or 15, the post dilation will be 17. Why? Because what happens after dilatation, the iris goes and crowds the limbus side, right? That is the reason where the aqueous outflow is happening. So therefore, the path is narrow. So how will the IOP get exited, right? So that is the reason for all of us, it will be 2 to 3 mm difference rise will be there. But for glaucoma patients, it will be a huge jump. So that you should be noting it. That is also one of the reasons where you're not supposed to dilate anything less than grade 2 and wait. Even the pressures are normal, no problem. Go and check with your consultant and discuss with that person and tell, can I dilate? And this is done. And then only you can do whatever has to be done. Okay. And after AC grading only, you have to take AT. Why? Because you're going to stain the cornea and you're going to indent the cornea. In that case, you have to check everything prior and then only, ma'am, I have a doubt in my refraction. After AT, can I go and do the refraction? It is absolutely not going to be helpful for you because you have already indented. So you have to wait for some time. You have to it because it is a central 3.06 mm which you have applanated, and that is where your visual axis, all the axes are the pupillary axis and refraction point is making sense. So if that is already indented and if you're going to, then there will be a change in the number. So always be careful. If you want to recheck, check before your applanation only. You want to recheck your refraction, you are a little doubtful. Okay, let me go back and check. Yes, you can do very much, but not after 80. It's not going to give reliable results if you do immediately. Okay. Okay, next is your pigment dispersion and all these things. What is this pigment dispersion? Pigment dispersion is nothing but the iris sheds pigments. Iris is pigmented structure. I hope all of you are confident about this. So that iris will what is happening? Moving up, the pupil constricts and dilates, isn't it? So when the pupil constricts and dilates, obviously there is a movement in iris. So that movement, the pigments in the iris just sheds and then go and block in the angle. So therefore, it is called pigmentary glaucoma, where the iris pigments blocks the exit pathway. Therefore, the pressure will rise. So this is called, and there is one more thing called pseudo-exfoliation, rubbing of the lenses, isn't it? So all these things you have to understand. Maybe you can pigment dispersion or all these are grade 4. ACD is grade 4, but still there is a rise. So never assume that only AC grade 2 will have glaucoma, AC grade 4 will have normal. No. Because of all these things, you have to be extra, you have to pay extra attention and find out all this. Okay. Either if the patient is known case of glaucoma, there is already a clue for you and you will know what you have to do. If the patient is new, then you see whether any brown pigments in the corneal endothelium or somewhere in the lower part of the thing, all these things you have to make careful attention. Okay. So I hope this, nobody has doubts till now. So what are the things which you are going to miss? That I have added even more little specific so that you will find it out. Next is your cup disc ratio, CDR, symmetry, NRR. NRR stands for neuroretinal rim. So what is this? See, can we see disc in this slit lamp? How many of you have say yes or how many of you say no? You can type there in the chat box. Can we see a cup disc ratio in the slit lamp examination?
Students, please type your answers in chat box.
Or only we have to dilate and see. That is how we are going to see the cup disc ratio. Good. I'm seeing the responses. Great. So all of you are very familiar. Good. So now, yes, you can see, but you have a specialized lens for that where you have to focus on the disc and you can see in the slit lamp. Even before dilatation also you can see, but the only disadvantage here is if the pupil is mid-dilated, you are lucky. If the pupil is little, once you shine the light, obviously constriction dilation happens and it will be difficult. But in case of a patient taking Pilocar is a glaucoma medication. I hope you all know that. So already the pupils will be myotic, isn't it? In that case, it is little difficult because whereas already the pupil is so small and you're keeping a lens and focusing and seeing and you cannot see. So exceptional cases are there, but yes, you can see. Just you can see because I cannot dilate. If it is angle closure glaucoma, then it is a risk factor. So maybe I will give a glance to see how the disc findings are. We optometrists can do anything. Document it and send it and see whether cross-verify whether what you have done is correct or not. And that's how we can learn and that's how we can improve. Okay. So yes, we can do. NRR stands for neuroretinal rim. Cup disc ratio, you all know that. This changes, you can document it, but no worries. Anyway, we are going to see the patient post-dilatation also. We can see there also. So you can correlate. So not an issue. Okay. So this much is important. And next slide. I will add. Okay, so gonioscopy. Okay, fine. Next slide. See, gonioscopy is an art. A beginner cannot do it perfectly. Even I cannot do. So it needs practice. It's like your retinoscopy. Like retinoscopy is a skill which you have to practice every day, right? Like that only. AC grading, yes, it comes with practice. But one thing which I would like to add here for 1 year grading is try to see the normal patients first. So that AC grade 4, 3 and all, you will be normally saying, okay, it's normal, I know. But once you see the normal patients and try to catch up an abnormal patient, you can easily find out something is wrong with the anterior chamber. This much you will come to a conclusion. And that's how you can build up yourself. That's how it has to be. And this is your gonioscopic picture. And here, again, it goes like Schwal baseline, ATM. ATM stands for anterior trabecular mesh, then your posterior, then your iris processes. Here, these are the small iris processes seen. So iris processes, yes, most of the myopes, you will be seeing the iris processes. Maybe next time when you see a myope, you can just try to do gonioscopy and check. And one more point here is, I said pigmentary glaucoma, right? So what will happen here is that I said pigments are going to block, right? So here there will be a pigment deposition too much blocking the pathway, right? So all these things has to be documented. See, if it is one small pigment, it's fine. If it is 1 or 2 somewhere in the whole 360 degrees, fine. But if there are more quadrants affected, then it will cause problem. Okay. So these are all the things which you have to do. So again, as usual, first try to do normal patients, then only you will see. The easiest way is using your 4 mirror. I think this much is enough for this slide. Next slide, please. Okay. 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 Here. So I know I'm not sure how many of you are seeing cup disc ratio on a daily basis, but just remember one thing, that is ISNT rule, ISNT. So the distance, the neuroretinal rim distance, right here. So this one, superior, inferior, temporal, and nasal. So superior, ISNT rule is I for inferior, S for superior, nasal, and temporal respectively. So the distance between this will be greater than your superior, and then this will be greater than your nasal, and then your temporal. So which is the least distance here? Temporal. That, just remember that. So that is what that rule, ISNT rule means. So in cupping, you have to know cup and disc ratio, that you have to know, and these are the blood vessels coming out. And the nature of the blood vessels, dipping here, bayoneting, wedge shape, all these things. So if you feel it is too much going beyond your head, just see practicing the normal patients first and see the cup disc ratio. And one more thing is, with this alone you can't do. You have to do a green filter. With red free filter you have to see. Then only you can demarcate the margins properly. So only with this filter it is not going to help you. Okay. The why this is important, to correlate your visual fields. Who does the visual field? We optometrists do visual field. So when optometrist is going to interpret the visual field, then basic knowledge of cup disc ratio is very important. Okay. So that is where here the role of this important phase of CDR comes. Okay. Next slide. Am I running out of time?
No, ma'am. Yes, continue, ma'am.
Okay. So this is what it is. And please see hemorrhages. You all know what is hemorrhages, right? So the thing is, here you have to see. Yes, very good. So this is the hemorrhage. Anything. See, when it is going to be diabetic retinopathy, we will see in the macula, we will see other. But when it is related to glaucoma, try to see for the hemorrhages here, which will be very easily seen. Okay. So this is what isn't rule is meaning here, and these are the changes. See, when you see the normal and see this, and definitely anybody would say there is a thinning. That is the distance between the rim and the pole is very much lesser. So therefore, there is super duper problem here for this patient. See here. Okay. So go to the next slide. Okay. Fine. Next. Okay. Okay, so this has to come prior, no problem. Now, when taking the IOP measurements, please remember that the semicircles should be equal, number one. Number two, don't apply too much of fluorescent or too less of fluorescent. Optimum fluorescent should be put in the patient's lower lid, ask the patient to blink properly and see whether there is any staining. Suppose the cornea is staining badly, please think twice before checking the AT. If you want, because if there is SPKs, 1 or 2 here and there is fine, but otherwise it is more in the central 3.06 where this cornea is applanated, you have to check twice. Okay, check with the consultant if you are not sure and then take it. So inadequate fluorescence again causes overestimation, underestimation, all these things will happen. Whether it is you're putting too much fluorescent, too less fluorescent, all with this result in the wrong estimation of your intraocular pressures. So that is the reason minimal optimal fluorescence should be instilled. Okay, so and one more important point which I would like to have here is don't make the sitting position of the patient and the examiner is comfortable, and make sure the patient has rested his forehead properly. And or if the patient is sitting at the edge and you are checking, and for you it will be 25 and for your consultant it will be 18. Why? Because maybe the sitting position is the problem. Maybe you could have missed that way. Okay, thinking 25, you could have sent for permission glaucoma and finally you should have landed up in 17. That's okay, because these are the sitting position, and don't give too much of pressure. Suppose the patient is not cooperative, what we will do, we will just avert the lid. But again, you should remember that you're putting the pressure on the globe. So as a result, the pressure might change. So these are the small things which you should keep in mind. And the patient who is wearing tight collars, again, there is a study saying that there will be a change in the IOP or rise in the IOP or whatever. So you have to be very careful. And breath holding, the patient is tensed and all these things can happen. So please be careful while taking AT. And NCT, no problem. You're just going to make the patient non-contact and that's fine. But here, as this is the gold standard, you have to be very careful in estimating. Now, one more point which I would like to add, which is very, very important here, is the central corneal thickness. So this Goldman applanation tonometry is estimated for 530 microns or 540 microns, which is a normal corneal thickness, central corneal thickness. Suppose the patient has done LASIK. You all know what is LASIK, right? So thinning of the cornea will be there. So that time it is not 530. It might be 100 microns less, right? 430 or 450, whatever, depending upon the size of the flap they have taken and kept closed. So in that case, can I tell I got a 16 in 80? So my 80 is this. Can I tell for a post-LASIK patient? No. You have to take a central corneal thickness measurement, see how much microns. Then you have to mention for that thickness, this pressure is right or not. That we have to find out, and then only we can go ahead. So my message here is, suppose, okay, LASIK it is 450, fine. Suppose if the patient is having 600 microns thickness, which is higher than the normal, again, the patient might end up in having 21, 22, but CCT is 600. So that therefore it is normal only. So for all patients, especially glaucoma suspect or glaucoma, all related to glaucoma, secondary glaucoma, please try to take the corneal thickness also. That will have a huge impact on your measuring the corrected IOP. Okay, so this you have to keep in mind. So just make sure your CCT is normal. And for people, even without LASIK, some people have thinner corneas. I hope you all agree. And some people will have thicker corneas. So in that case, we have to take, instead of going on the probability of who is having, who is not having, it's mandatory to check CCT for all glaucoma patients. Okay, at least once in life. If it is post-LASIK, you have to take CCT compulsorily. Okay, so that's about this slide. Okay, let's go to the next slide, please. Okay, here, yeah, it is written. Very good. So this is what I mentioned. I hope this is very clear. So now you, ma'am, how will I know the correct IOP? What is that? There is a formula for that and there is an estimation for that. You need not worry about that. The consultant will take care. Just that make sure you mention your CCT and your IOP. That's all, nothing else from our side. Next slide. Yeah, this is most important because only optometrists, as I said earlier, only we do most of the clinical diagnostic procedures, isn't it? Now here, most of the mistakes people do here is your data entry here wrong, your amount of what strategy you have to use. For example, here it is theta standard and pupil diameter. So how pupil diameter only we write, isn't it? So check the pupil with a torch, whether it is dilated or not. If it is in the undilated stated, no problem, you can write. But make sure you see the pupil size and enter here, not default setting. No, that won't help. So vision 6.6, and this is called
Meenakshi, in the meantime, you can complete this quiz answers. No?
I have to stop sharing and reshare it, ma'am. I guess if ma'am finishes, it will be better.
Oh, it is, she has shared it, huh?
I am sharing it, ma'am.
Okay. So,
I guess ma'am is back. Ma'am, you are muted, ma'am.
I'm sorry, there was some problem. I'm very sorry. So here, can I continue?
yeah, no problem.
Okay. So please make sure this data entry is done properly here. What is the strategy you are using, whether it is going to be 24-2, 10-2, whatever thing. And next, see, we do for three reasons, sorry. One is to find out whether it is glaucoma patient or any neurological problem, or it is related to any retinal pathology like retinitis pigmentosa, where the patient will have night blindness and tubular veil. So based on those conditions, you should understand what strategies to use. And we optometrists only decide that also, isn't it? So if it is going to be RP, it's going to be 120 point screening. And if it is going to be glaucoma, mostly 24-2. And if it is for neurological, it is 30-2. Sometimes people, if it is glaucoma and neurological, then you can no choice, you don't have choice, you have to use 30-2. Okay, like that you have several strategies which you have to understand. And I hope you all know, I will just briefly tell, I will not explain in detail. This is called your grayscale. This is your raw data. Whatever the patient is pressing, you will be getting there. And make sure your foveal threshold is on. Most of us we do here is by mistake, when we put it as off. Check well, first thing is you have to check your fovea is on or not. So first this 37 will be your central fixation dot, where you will ask the patient to see at the center of the 4 dots. And whenever the stimulus comes, the patient has to press the button. Okay, so this is your fixation monitoring, whether the patient is seeing properly or whether he has understood the test properly. For false positive, false negative, fixation loss, all these things you can monitor here. So just explaining the test and give a demo for 30 seconds or so, whether he has understood the test, then you can start. So this is your grayscale raw data, and this is your total deviation, pattern deviation, the numerical and the respected graphs. Okay, respected scrotum and the blood raw data. Okay, so here again the mean deviation value is here with the decibels and PhD. This one is given in this with a probability of less than 1% and 0.5 respectively. And here, this is the glaucoma hemifield test, which says outside normal limits or within normal limits. Based on the report, it gives a one statement, whether it is outside normal, within normal, or generalized reduction, which is overall reduction based on the age. If it is 50 here, then it will give GRS, or 60 here, it will give GRS based on the report analysis. Okay, so this is the value which you have to remember. So here, most importantly, as when you're performing, you just wait here. If it is going more than 5, 6, then stop the test and redo it. Instead of waiting the entire test to get over and taking the printout and asking the patient to do again, it's not going to make sense, because the patient has to do properly and you have to get the report. So based on this one more important point, your retina and the visual field is opposite. If your nasal point in the retina will correspond to the temporal. That is one more important point here. So next slide. So this is what it is, and this is your RNFL thickness. So this is your quadrant. Obviously, we all know red is abnormal, right? And again, you have a way to here, you have a signal strength, all these things. Like there in visual fields, you have got the fixation loss. Here you have the other parameters, whether the test has been done properly. And please be careful about your imaging, OD or OS. All these things you have to. And make sure you do an analysis properly. The scatter plot and sector plot and all these things. Next slide. Okay, the same thing. The double lump pattern is what you have to see here, which is most important. Okay, next. And why this is in black and white? So spectral domain OCT, again, depending upon the type of imaging. So please remember one thing, structural test is different, functional test is different. Functional test is your visual field and structural test is your OCT, HRT. It is not mandatory to do all the tests for one glaucoma patient. Whichever is required, mandatory, you can do it. Next slide. I think I have covered everything. That's it from my end. If you want to have anything to ask, you can ask. And this is your angiography, OCT angiography. So that is the image, you get it here.
Thank you so much, ma'am. That was a detailed explanation. Thank you so much, ma'am. We got a couple of questions in both YouTube and in the Zoom, ma'am. So shall we start this session, ma'am? Yeah. So first I will cover the questions from YouTube, ma'am. The first question is, so how to prevent glaucoma if there is a positive family? Is there any prevention?
Okay, that's a good question. So basically, glaucoma is a silent killer, right? And you have already said you have a positive family history. The best way to is go for a periodical checkup right from the 40. Do a periodic, and if you are absolutely normal with your IOP and with your everything, disc is fine, then field is also normal, then go for 1 year follow-up mandatorily. But if you're under disc suspect, they're suspecting you might develop a glaucoma, then you have to go for 6 months follow-up. This is most important. And educate the family, like your family, other people, your cousins or whoever is in the, like if you are aware of this, then you can educate awareness to others also, as this is a silent killer.
The next question, ma'am. In case of normal tension glaucoma, is it got any impact on the optic nerve rate?
Yes, see, these are all the different types of glaucoma. Normotensive is the pressures will be normal. Again, as I said, your indicators are your central corneal thickness in the normotension, because the pressure is normal. Check for your CCT, then your optic disc findings, then your visual field. These are the parameters. Suppose if you are not sure whether the patient is having, there is something called pre-perimetry effects which can be picked up, and you can ask for structural test. Structural test, that is your RNFL or your HRT, where it is going to pick early, isn't it? The structural changes are going to happen first. Maybe that you can we can advise, and based on that you can put it up. Or a simple diurnal variation test will also be helpful. If all these are suspicious, this is still confusing, then do everything and then follow up after 6 months.
So what are the kind of medications that can cause glaucoma, ma'am?
What are the kind of medications? See, actually, the basic thing is, see whether you're taking steroids for anything. Systemically also you might be taking. If there is a patient who is having renal transplantation, who is prednisolone 5 mg, visolone 5 mg, 2.5 mg for months, then he is an indicator. Why? Because of this secondary main changes, yes, secondary changes in the eye. It is not only glaucoma, you can have secondary cataract also. There are other changes. So people who are having asthma, I said already. So all these things, people who are under steroid exposure should be having, you have to check. And second thing is, patient who is having uveitis. Again, they are giving topical steroids there. Again, you have to check all these things. So most of the steroid related things might cause your glaucoma earlier than what it, even though you don't have a family history, still you are in the risk factor. So steroid in any form, topical, oral, all these things are an indicator. Suppose the patient is having neurological problem, IVMP for a long time, So again, so these are the things. which
And
I think-
another question is, if a patient has been prescribed for glaucoma medications, how long the medication has to be continued?
So that optometrist cannot say, only the ophthalmologist can say, right? So basically what I would like to add is, once you open the bottle, from my optometrist point of view, don't try to use it here. It is expiry 2027. So I will use until the drop is over, till the last drop, which is available. No, once you open the bottle, maximum 1 month. Don't try to use it longer. And based on your allergic reactions, the consultant has to tell if you're having, maybe if the drop is not effective, maybe the change of drop, beta blocker or any other things, any other combinations will be suggested only by the ophthalmologist.
The next question is, if a patient is coming for the checkup, for the routine checkup for glaucoma, the patient has to take the medications in the morning before coming,
Yes.
or it has to be taken?
No, unless and until the doctor says, please don't take the medication and come tomorrow, then you have to put. Don't wait. So this is a myth actually. This is a very good question. People think, okay, I'm going, I will not put. Because of that, the pressure would have raised, but the patient wouldn't have realized. The pressure would have gone to 25. So that you have to, you put. Suppose the patient's disc findings, IOP is not related to, maybe he's just a suspect why he has to put 2-3 drops. Then in that case, the consultant will advise discontinue for 1 week or so and come back after a week, or maximum 2 days or 1 day. As per the ophthalmologist's decision, you have to discontinue.
The last question, ma'am. If cup disc ratio is 0.5, does it mean that I have glaucoma?
No, there is many, only with cup disc ratio, we cannot tell anything, right? So there is something called physiological cupping. Physiological cupping means 0.8:1. So, but still the patient is healthy. But how can we tell? We have to do the visual fields. We have to do the structural test, any of the HRT or OCT, and then come to a conclusion that it is not the pathological condition, but it is just a physiological condition. So just by numbers, we cannot tell anything. You have to correlate with the structural and functional findings.
Thank you so much, ma'am. So those were the questions. Thank you for your patience, ma'am, for answering
Thank
for
you
all these
so much.
questions. Yes, ma'am. So we
Thank
had
you.
quiz in between, right, ma'am? And because some responses in both Zoom as well as in YouTube, we quickly discuss the answers for the quiz. I request Meenakshi to kindly pitch in.
Yeah, thank you, Gomati. I see many interns and second years answering. We are very happy to see the answers. So we'll start with the question number 1. We asked which population is very prone to get glaucoma. So the picture in the risk factor says that it is Americans and the Africans who are very prone to get glaucoma more than the Caucasians. Next question number 2 is whether the ASOCT shows it is an open angle or closed angle. The angles you see here is actually closed. Third question, normal cup disc ratio. It is nothing but 0.3 to 0.4. But doesn't mean that, as ma'am says, if it is 0.5, we doesn't conclude as glaucoma. We need to check other findings also. Question number 4 is normal IOP range. It is 10 to 21 mmHg. Last question, name the angle structures. From the iris to Schwalbe's line, it is iris, ciliary body, scleral spur, trabeculum eschwag, and Schwalbe's line. Thank you, Gomati.
And I would just want to add on the second question, ASOCT.
Yeah,
So
ma'am.
here, please don't get panicked if your answer is wrong. Even initially, it's a black and white image. It is very difficult to identify. The scleral spur is only indicator. So don't worry if you're not able to answer is right. And the other alternative for this is your UBM, ultrasound biomicroscopy. So these are the two images which we'll be seeing in black and white, and where you can assess the angles. Thank you.
Thank you,
so
ma'am.
much, ma'am. Thank you, ma'am. Thank you, Meenakshi. Yes, Maheshwari, ma'am.
So,
What is the-
yeah, you can unshare PowerPoint. So as we were all thinking, one second, Jemima, can you? So as we were all thinking that glaucoma is something very difficult, only the ophthalmologist can handle, and OCT and or UVM, only when you do that it's really a good one for glaucoma. But Shenbagam has clearly explained about how history is important, from starting from very basic, and when you take a proper history, most of your work is solved, right? So she gave an excellent example of migraine, taking a medicine for for migraine. So this simple examples, we were seeing all our practical examples. Like for example, she said post-LASIK condition, where we see that we get an IOP value and we think that it is normal, but actually it is not normal. Or there's a condition where it's a 600 microns of cornea, where even though we get a higher IOP value, it could be normal. So these are all very practical examples. So we won't get such knowledge when we Google out from the, so it all comes from experience, and we see a lot of practical inputs today, and it's going to be there in the YouTube. Please, share it with everyone, and anybody who's practicing, simple practitioner who's having an optical outlet, they are having a slit lamp and an AT. So they can do a lot of work with this practical knowledge. So I think it will be this time that we spent, this 1 hour, so it will be really useful for each and everyone listening to this. So I would like to thank Shenbagam for excellent practical inputs that you have given. So hope this will be useful to the students.
And I thank the entire team once again. Thank you for this opportunity. Keep rising and keep shining.
Sure. Thank you so much, ma'am. We're so glad that you have been on today. So thank you so much, ma'am. I request the audiences. Yes, ma'am.
And I would like to make a quick announcement that we have started our admissions for the next academic year. So admissions are going on, and as you all know that Dr. Agarwal's Eye Hospital is there, everywhere around the world, and around 200 centers around the world, and you'll be getting a real practical exposure. And now over to Gomati, so you can tell.
Just Gomati, can I add one more if you give me some time?
Yeah.
Actually, I just want to tell about Sushant University also, which was there in my mind. So basically, we do run undergraduate and postgraduate as like 4 years and 2 years. And one more new course, which is not new, it's been running, but I'm not sure how many of the candidates know. We are having a master optometry in practice and research. That is, it is like a distance mode kind, but they have to visit the campus once in 2 months. Sorry, 2 months once for 2 days. So they will just for any session 1-to-1, because they will be practitioners. These are the people who are working and they are they wanted to pursue, but they couldn't because of their work situation. So for them, it is open, and the criteria is just 1 year after your bachelor's. If you have 1 year clinical experience or more, well and good, you can join. Maybe if you're anybody who is interested, maybe think about it. Feel free to ask. I will share my email ID to Maheshwari. Maybe you can share it to others.
Thank you.
Gomati, you have anything to ask?
Yes, ma'am. So for those who are seeking admission, Dr. Agarwal's Institute of Optometry, especially for bachelors, I share the number of course coordinator and the online registration form in the link in the description. So please do kindly follow that. I would like to thank all of you for joining today. So thank you so much for making it such a wonderful session. Shenbagam ma'am, thank you so much for joining. I would like to thank Maheshwari ma'am and Jemima ma'am and Meenakshi for the cooperation. Thank you so much. Audiences, if you have any doubts, yes, ma'am.
One more thing, so I would like to thank Gomati and Meenakshi, and a special thanks to Gomati for coordinating with Shenbagam and making things and
Shenbagam ma'am is too sweet, ma'am. So thank you so much for introducing, ma'am.
Thank you so much for the compliment.
So I would like to tell the audiences, if you have got any doubts while you're watching the video, please do post your questions in the comment box. We'll get back to you with the answers. If you like this video, give a thumbs up and share it with your optometry community. So do share the page as well. If you want to know more happenings and updates about the college, please do follow our Instagram and Facebook page. I'll attach the link in the comment box. Thank you so much, everyone. Thank you all. Meet you all in the next episode.
Bye-bye.